Well, here we are, another episode. What are we going to talk about today, Renee?
Hey, today we're going to talk about workforce and the world that's different in the last 4 years since what are we calling that? The event that happened 4 years ago. And talking about chronic stress, burnout, and how it's impacted our workforce. And just really talk to listeners about the workforce itself and what does that look like in behavioral health, and then some suggestions and ideas for improvement. So we're going to be talking about what it looks like out there and what the train looks like, and then getting back around. But before we dive into all that, Jason, what's going on the farm this week?
Weeds. Been spraying for weeds.
Oh my
I
gosh.
don't like weeds. So,
Oh my goodness.
out, making sure that we're getting the right nutrients and managing those weeds because they just show up out of nowhere, Renee.
I just ran into a good friend of mine, Senator Annette Sweeney, and I will never forget this. So back in the day when we were in the legislature, they made this pretty postcard for her with 4 different colors of state Iowa flowers. And one of them was that purplish noxic weed that you all hate that takes over your fields, that purple one. And she pitched the biggest fit because she's like, you can't put that on my postcard. That kills crops. And so it was city people making the postcards, and they picked it out as like one of the Iowa pretty flowers, and it was actually a weed that destroyed things. And we just reminisced on that
Yep.
this week. So I was just laughing, going, yeah,
See,
not all weeds are really friendly,
not
and
all
they cause
flowers
them.
are nice. So
Not all
that's the
flowers are
lesson.
nice.
That's
True
our takeaway.
statement. And around my part of the urban part of the world, everybody's like leaving their lawns for bees. And so it just looks like a big old hot mess. And so they put these signs in it and pretend like it's for bees, and we're not going to mow for bees, or whatever those little slogans are, whether it's a May or June or July, we're not going to mow for weeds. But you look at it and it just looks like a big old jungle of disaster. So I don't know. I don't know if that's better. I don't know. There's just so many weeds, so many weeds. So to kick us off, let's talk about where we've been the last 4 years with chronic stress and burnout. And we've tracked this now. Jason specifically has tracked the data on this for the whole time. So where are we, Jason, today in comparison to where we were 4 years ago? And how are we doing in stress and burnout
Actually,
in the
it's
workforce?
actually 4 years, 2 months. Not that I'm keeping track,
That's a long time.
Renee, but it's been a long time, right? And overall, our collective anxiety and depression has been two, at maximum, 3 times higher than it was going back 5 years ago. And so we're finally starting to see, I think, a little bit of stabilization. Those numbers, if I look back to April of this year, those numbers were down to, 18% as compared to 11% pre-pandemic. So the lowest it's been for any recent history. So that gives me some hope that we're starting to stabilize. But we also have, really the scars of the last 4 years of that really high anxiety and depression. And I think we see that in our workforce, right?
Yeah, we do. And I know we've talked about this a little bit on previous podcasts, but our office had to move for some reasons and to go to temporary space and stuff. And there were some different folks in our office that during the pandemic were considered essential workers and had to be in the office by themselves. And you still are just feeling the fallout of, how people were treated during that time, whether they got stuck at home or whether they lost jobs during that time or they were essential. And it's all playing out differently. And so the stress and anxiety levels are not consistent across all employees or workforce, but you've got to have those individual conversations to learn where that individual person is today. Because I think there's still some folks that probably, what we're talking about here is an average of 18%, but there's still going to be some folks that run high and some folks that run low. And so just checking in with people, it's not as just everybody's okay. It's still not there. So I don't want everybody to think, oh, we're back to normal, everybody's okay. I don't know what normal is. We talk about that, but I also don't think that we're past that curve of making sure we're asking. Because maybe, Jason, what do you think? Some people just got tired of answering the question, potentially. Who knows?
That could be, I think we've
Possible.
also become a little more accustomed to the flexibility, right? I think we're just
Yeah.
finally settled in that some folks' role, we just have to accept a new level of flexibility. And I think maybe supervisors are finally starting to sort out, how do I let go a little bit more? Because I think it's gotten to the point of we're not turning this back. So we're going to have to figure out a new way forward.
Yeah, I think we've talked about this from my own office, and we're moving toward like accountability measures to show when people actually get the job done, and then make that be the goal rather than the time or the butt in the seat kind of thing, or the time in the building or whatever, and trying to be like, okay, these are the jobs, and even putting some timetables to that, because the other issue is because we kind of have one of each particular role, and sometimes different types of parts of the job if you don't get your part done on time, other people can't do theirs. So looking at two parts, not only just, how to hold them accountable to their work and when they do their work be done, but also then making sure they do it timely enough so that their other members aren't being held back. And I think if we can get some of those kinds of SOPs in order, standard operating procedures, sorry for the acronym, and some accountability, I think that flexibility can happen. But you're right. I think it's really forcing people to have to make some choices they might not have wanted to, because there's a lot of empty building space in most cities around the country where people used to have to go to the office and people just aren't coming back. And so workforce is kind of dug in on this and kind of getting a say. And I think maybe that's a good thing for everybody. Maybe a little more balance, as I'd say, or blend, as you'd say, is good for people. I think maybe that's a place where we're going.
Yeah, and I hear the term workforce shortage a lot, and I think it means a lot of different things. And so, maybe we should take a minute and kind of talk about what does it mean? Does it mean people don't exist, or does it mean we don't have the level of training coming in of new employees, or have we lost some of that higher level, I think, of employee that used to come to our door that now we have to spend more time training, more time getting to know. And I don't know if it's one or the other or a combination of both that kind of has us in a struggle right now.
Well, if you think about some of the newer people to the workforce, some of them ended up in school and everything was online because things were shut down and all of that. And so they didn't have all the same opportunities for internships and for hands-on experiences. And then the world of education in general has changed to more online. So now people can get, for example, I'm a licensed clinician, and now people can get that 100% online. I can't imagine my life or my job having been that way because I was so hands-on when I got my license and degree. But nowadays you can get it online. Well, that produces a very different employee. When you come out of the office, when I was a bachelor's level social worker, I was in a psychiatric hospital working as a technician, hands-on with clients. And so as I got my degree, I was hands-on, moving from unit to unit, internship to internship. And by the time I was done, I had several years worth of clinical kind of experience under my belt with supervision. And folks that are getting online degrees, or even the last ones that maybe didn't intend to, but they did because of what happened with the world shutting down, they just come out different. So you're right, there is somewhat of a different training. And then the second group of folks are those ones that have been out of the workforce for a chunk of time coming back in. And so whether that's by age and necessity, now they want to return because maybe they didn't have the retirement setup they wanted to be able to sustain, or maybe parents who've raised their kids now returning to the workforce. And so training is going to need to be a thing. You have to look for the person who's trainable, not necessarily that they have the skills already in their sack. It's what I've found.
And if we look farther upstream, I know some researchers who are constantly looking ahead to kind of what do we see on the horizon. I think about the absentee rates of kids, middle school and elementary kids today, and we're seeing 3 times higher absentee rates in our secondary education schools. And so I think, in 10 years, what is that going to mean for the workforce? If we're already complaining about workforce issues today, what's on the horizon? And so I think we need to take a kind of a long approach to this as to, how are we looking at this and how are we approaching this as a society?
Yeah. So today we're going to kind of dive in specifically to behavioral health workforce. And some of you listeners may know all of this, and maybe this is new to you, but there's a lot of data out there. We're going to have some places noted in our show notes where you can see it, but really talks about some of those shortage areas and some of the things that we struggle with as far as behavioral health. So Jason, I know there's some data there. Is there anything specific that kind of jumped out to you about what kind of providers we have or where the shortages are or anything like that that kind of jumped out for you?
Yeah, well, we know rural areas struggle more than urban areas, right? Like it's really hard to recruit and maintain folks in rural areas. Half the counties in the United States don't have a practicing psychiatrist. And so, I think that's really tough to have that conversation of how do we provide healthcare and specialty healthcare in rural areas? How do we provide access and how do we create equitable access across the board? And I don't think there's easy answers to that, but I think it's a challenge to say the least.
Yeah, and there's additional data even showing, like, as of December 2023, that more than half, or 169 million people in the US population, lives in a mental health shortage area. That's a lot of people. So that's not just rural, as we think of rural, if 169 million people in the US live in a shortage area, shortage areas are in your cities and your towns as well, especially regarding specialists or different types of behavioral health providers. And so we really struggle in this space. And it's not just our state, it's everywhere. So we can't just borrow, beg, or steal from the neighboring states. And so I appreciate some of the work being done, say, on compacts to try to bring licenses across borders, but the neighboring states don't necessarily have more than we do. So it's not just going to be some quick, easy fix to sit back and think about some of the challenges. And then if you start thinking about your underserved groups or groups of specialty areas or specialty needs, the numbers get even worse. It's even harder to find services in our community as we become more open to refugees, people of different backgrounds and different languages. It becomes even more difficult to find, help for folks.
Yeah, absolutely. And as you talk, I think about, as we think about shortages, then I think about how do we provide culturally competent care? How do we design our systems and approaches to meet the unique needs of our populations across the board? And that becomes even more difficult throughout all of that.
So we're thinking about like other areas as shortages, and like you said, rural areas struggle more, but it's not just behavioral health, but primary care health is also really important and is not as easily available in rural communities as it used to be. And Jason, why do we use in behavioral health, why are primary care offices so important? Where do you see that gateway connecting to behavioral health?
Well, I mean, we both know that someone who's experiencing a behavioral health condition is more likely to go see their primary care physician 2 or 3 times on average before they go see a mental health clinician. And so, we know that primary care is a great access point. Unfortunately, it's been really difficult for, that part of the healthcare system to really embrace behavioral health, right? And so I think we're moving into a time where we can have some honest conversations about how can our healthcare system truly treat the entire body, which includes from the neck up. And I think that's been the challenge over time, right? It's been more socially acceptable to see my primary care physician in some areas because of stigma than it is to go see a mental health counselor. And so I think we're getting to a point where we're going to see a merging of those systems, especially in those underserved areas, because we're going to have to consolidate around where the resources exist. And I think that's actually an opportunity to create better care, to streamline our systems, to create efficiencies in a way that we haven't been able to do before.
Right. And we've talked about this in a previous podcast, but a couple of things just came to mind. One, we've talked about duplication of services in some areas, and that is going to be lessened by the fact that you only have so many things. And so you're going to have to be very strategic about what you do. And the other piece is thinking about how the CCBHC conversation, the Certified Community Behavioral Health Center conversation we had a few podcasts back, even planting primary care into those locations or connecting that agency to them or somehow connecting it to primary care. And so both of those options really start talking about, making sure that we use the people that we do have to their fullest capacity. And then, thinking about doing it all in one location makes a lot more sense.
And we haven't always talked about our public health workforce as being an opportunity. But, I think our public health workforce, as we think about prevention and getting more upstream, is how do we connect with our community health workers, right? Because actually they play a role in our overall community health. And how can we do a better job of integrating all of that healthcare continuum to include prevention, which is what public health is really good at. And so, I think that it's not just about introducing behavioral health and substance use to primary care, but introducing prevention and community health and our public health workforce, right, into really unifying healthcare in those underserved areas.
Right. And in our state, there's been some legislation this last session done in this area, and some of it really ticked off a lot of people, but in two different pieces. One was the behavioral health big reorganization, putting together behavioral health and mental health, because they've been kind of separated providers, even though we've been told for now, I don't even know how many decades, that we're supposed to be together. They're still separated and two different funding streams and two different state departments and all of that. So bringing all of that together should reduce administrative waste and bureaucracy and redundancy. That's the whole point of that decision. And then the second one was in an AEA area, where that is like, if you look at who had the most psychologists in our state, they always were there, but not necessarily hands-on with people who needed services. And so it was kind of, if you will, sort of hoarding the talent to do certain things. And so people were really mad about all of those things, which is, you can have an opinion, is fine, but I get what they were trying to do, because it circles around this workforce idea about, flattening out administration, not having as many districts, not having as many administrative leaders, and putting people back on the front lines to actually do the work. And it'll be interesting to see as this all unfolds, because we're not quite where it's going to implement yet, what all this looks like. But you can see behind the idea that it was reducing waste and duplication, at least one part of it. There's other pieces, but that's a part of what they're thinking. And I think it's really important. So Jason, we've got some ideas on behavioral health workforce specifically that apply to other types of health workforce. But when we're talking about trying to expand who we have and expand access, what are we talking about there? What are some ideas or things that we can do? And then we can tie those into some stories of things that we've seen as we've gone out and done our work. But what are some ways to improve our numbers in the behavioral health workforce?
Yeah, we have to think differently about who is our behavioral health workforce. It's funny because I was sitting in a state work group meeting. I've been invited to provide some insight, which kind of makes me laugh sometimes. And one of the things we're looking at are steps to increase workforce, exactly what we're talking about here. And it's come up numerous times of, well, what about those with lived experience? What about those certified peers who could be providing some level of peer support, peer education, right? A whole area that's really untapped right now.
Yeah,
We set
100%.
up a decade ago peer certifications to professionalize peers in three different categories in the state of Iowa. A lot of states have different levels of certification, or kind of a mid-licensure type level to professionalize it, so that there would be a certain level of training, so that it could be potentially billable to Medicaid under certain situations. And there's a whole workforce that's gone untapped.
Yeah.
And so I struggle with having empathy sometimes when people tell me there's a workforce issue, because I realize the duplication, I realize the resources that we have access to that we're not utilizing,
Right.
because it means we have to change our practice. And so, I think the first thing we can do to bolster our behavioral health workforce is to assess what is our behavioral health workforce and how do we leverage what we have differently, or use those
Yeah.
resources that we're not currently leveraging today.
Yeah. One story that pops in my mind, and you're going to remember it very vividly once I say it, is about peer support, is related to people who sit in the emergency rooms in some of the
Yeah.
states where we've worked. And they call them sitters. But the people who were sitters are like high-level administrators, or whoever had a shift, pull in extra double shifts, triple shifts to sit with persons in emergency departments who, so the amount of money sitting in the chair is ridiculous when you could have peer support who would be way better at it and well received by the person that was in crisis, sitting next to them and compensating them at a reasonable rate to do a really better job of actually helping in a crisis than an administrator ever could do. And that's just one example, right? But we think about in the police stations or the jails or the access centers where people are left to sit, and it could be your police department, and a sheriff deputy is left to sit until somebody gets admitted. Why aren't we using peers and persons with lived experience who've been through that process, who've been in the hospital, who've sat in the emergency room, to be there to intervene and to make that person more comfortable, instead of having a sheriff in their deputy uniforms? And why are we not doing this? And it's been, like you said, a decade in the works, and we're still just not even really considering them as we should in our workforce.
We could give example after example of the wrong person being put in the wrong position over and over again. We still have mobile crisis teams in this state who will only send licensed clinicians out in the field, which is a misuse of a licensed clinician, because Chapter 24, other credentialing, clearly says you can send a trained bachelor's degree person out to do that work under the supervision of a licensed clinician, right? So we're using people with really high credentials in ways that then is taking away from their ability to do the work when we really need them to do that. And so I think those are all examples of using the wrong level of clinician at the wrong time. And if we were more efficient utilizing what we have, think how many more people we could serve.
Yeah. And so another piece of our behavioral health workforce that we need to talk about, and this one drives me crazy also because it's another policy that's been in place now for a while, is reimbursement rates. And I know we get really frustrated about talking about it, but we have existing parity laws, and we've done work in our state, and many other states have done work on making sure people get reimbursed equitably, the same as they would for healthcare, because it's healthcare. Behavioral healthcare is healthcare. We can't say that enough, but it's still a problem. It is crazy to me. And so really having to think about, enforcing the laws that are often on the books and making sure that people get reimbursed. Because again, in behavioral health, if you're only getting reimbursed a portion, and I know one of the clients you're working with now, they'll take the private insurance cases, and there's always beds open for private insurance, but they won't touch Medicaid. And you can guarantee that's because of a reimbursement rate issue.
And sometimes it is, and sometimes it's not. Because I've also had conversations with those same groups and said, well, is it a reimbursement issue? And there's silence.
Mm-hmm.
We were recently at a meeting with a bunch of executives from a hospital, and I said, well, what's the resistance to the traditional, and it's a stigmatized Medicaid population? And I go, well, what's the issue there? I go, is it dollars? Do you not get paid enough per day, per diem for those patients? And it was silence, right? So sometimes it is a payment issue, and sometimes it's well, we don't want to meet the obligations, or we don't want to meet the contractual obligations. Well, that's part of your role as a healthcare provider. And so, we have to balance with, there's a certain level of accountability that comes with accepting some of those reimbursement rates. Here in Iowa, outpatient rates have gone up extensively. In the last year, there was a complete equalization of
Mm-hmm.
rates for outpatient providers. But I still hear it sometimes. I'm like, well, wait, you get paid the same amount for outpatient across the board, the same as you get paid with private insurance. You used to only accept private insurance because there's a payment issue. Well, now why aren't you accepting all funding?
That's right.
Okay. And so I think that sometimes that becomes an excuse. And so I think everyone should be funded for the services they provide, right? Don't get me wrong. I think whether you're for profit, not for profit, that healthcare should be reimbursed for what you're doing. But I do think also when you're engaging ethically in these types of services, then you have to be honest with why or why not you're not taking certain clients.
Right. Well, that really ties into kind of the next thing on the list about what we can do to increase the behavioral health workforce. And it really is aligning the paperwork among the funders. So you just said that, right? If it's not the reason of reimbursement rate that they're not taking it, it's because there's the hoops that then happen to get paid. And man, we've heard story, and it's still a thing in our state with certain managed care organizations who you have to bill and rebill and rebill, and they could be like almost a year in the rears of trying to get paid for services. And our behavioral health providers just don't have like all this extra cash sitting around for cash flow to not just be paid. And so it is a problem. And if you've got different requirements for the different types of reimbursement forms and whatever, some I've had friends that just limited who they would take or how many insurance companies, or including Medicaid, how many they would do, because they just don't have the time and the bandwidth to do the paperwork. And
I
that's something that
wish,
should be fixed.
yeah, I wish someone would come on with us at a future podcast and just explain to us the funding barriers. Because, even when I was an executive, I had billing departments and I had, people that would tell me, even today, I go, I sit and I listen to Medicaid meetings and I look at the data, right? And a third of all claims are denied, like
Yeah.
off the bat. And I'm like, we live in a technology, like all of that is uploaded electronically, it's cleaned. Like, shouldn't we be able to do better than that? At what point can we use and leverage our technology? Like, if someone's Medicaid eligible, and those things have all been checked on the front end, which most all of the organizations I work with have systems that automatically, right?
Mm-hmm.
I know folks now that AI checks the note content and the billing content before a claim even is submitted, right? Because that's integrated in some of the electronic medical records today. So everything is checked and verified before it's billed, yet a high percentage of those claims are still being denied by the Medicaid managed care organizations. And I just can't quite understand that, Renee.
No, I can't either. And I wish it was just, I mean, I don't wish it was just, but I'm saying that it's not just on the behavioral health side and it's not just Medicaid. Your insurance companies are doing more and more of this to most people. You're getting weird charges for stuff, or they're saying that was out of network. And I'm like, how is that even possible? Because it went through my primary care with a referral. How is that even possible? And so there's just a whole lot of that back and forth in everyday insurance these days. But for providers, that's a big, big deal. And if you talk to provider groups, they've had to sometimes have to hire specific people whose sole job it is to track down all this crap to get paid. And so that's extra, administrative costs off the top that doesn't really help with the reimbursement. Another one we talked about here for behavioral health workforce, and it's another one in that financing space, but loan forgiveness and scholarships. But then the training opportunities that come on the backside, that's two different pieces, but both of those are struggles sometimes, because we have struggles in our state sometimes where people can't find supervisors. They can't find people that'll help them, get that next level training that they need, because again, that is taking away from somebody who's probably practicing. And if we're already short the number of people practicing, then they have to take time out of their schedule to supervise somebody else. But it's hard to get your mind wrapped around doing that for the next workforce, next generation, while you're so blacked up with so many clients of your own. So talk about that. What are your thoughts on loan forgiveness, scholarships, training, all of those things? How could we help our behavioral health
Do you
workforce?
really want my thoughts on all
I
these
do.
items, Renee?
I
Because
do.
I have so many opinions, and
That's
although
good.
they're
Tell them.
solely opinions, I think training. I think the first thing we have to do is get honest with, for years there's been a disconnect between some of our higher education institutions, and training, both from an educational perspective, and I just recently I know people who really want to give back to their profession and want to take interns. And the requirements were so
Mm,
overwhelming for that initial
hmm.
training, which is so it's really a disservice, right? Like, people need good training, they need good supervision, they need that high level of touch in the beginning to ensure they're getting a good education. However, when it goes over the top, then it takes away from someone's ability to do their own job. And it's like a full-time job just mentoring someone else, and then it
Yeah.
becomes unreasonable. And so, I think that there's such a disconnect between some of our institutions of higher education in order just to get that initial temporary license, yet alone the supervision then required to get your license. And I'm all for upholding, the ethical, credibility of a licensed professional. However, I think we're going to have to find some balancing between how do we get people the training and the structure they need to get to the next levels, but be reasonable, especially in rural areas. We have to think about telehealth. We have to think about other ways that we can connect and mentor. And I think we really need to think outside the box as we move forward, because all of those things, as much as they're needed and necessary, can really be barriers in getting new people trained and to the place they need to be so they can practice.
Yeah, and then there's some chunks of training that are just flat missing. I mean, all the stuff we just talked about with billing and all of that, there's no classes
Right,
on any of that. Or if you
right.
want to run a private practice, you don't get any kind of insight on that. And so you're just sort of kicked out to run a business. It's a business, and you have to be smart about that. And so we've talked about people getting stuck in some non-compete clauses. You don't even really get taught about that stuff. So you come out and you're gunning for your first job, take whatever job's available to you, and you get stuck in a horrible contract making much less than you should be, and you don't even realize it because you never got the business acumen in the degree to know what you're looking for. So the training is like what is included versus what's not. And then, like you said, making sure that there's people out there. We need good people teaching in our institutions. But again, that takes them off the bench of actually providing services if they're teaching. And so it's not just our field, it's nursing, it's medical, it's everywhere. But getting good instructors is hard because it pulls them off the bench and you might need them. And so it's just a hard spot to be in. But those are good things we're thinking about. I know next week, Jason, you wanted to do a deeper dive, but give everybody a taste of what are you thinking about with telebehavioral health, because that's a thing we could do to expand our workforce, and innovative partnerships. Give everybody a taste, because I know we're doing deeper dive next time.
Oh, we are, and I'm not one of those people who comes in and says, well, we should just do everything by telehealth, right? Telehealth
Mm.
is a tool, and I want to just make sure we're leveraging that. But even beyond telehealth, it's really about the innovative partnerships that we can come up with, and as using telehealth, but thinking about what other innovative partnerships can we create within our communities or within our states or within our regions that are able to do things that we can't do today. And I think so oftentimes we discount different options, different opportunities for collaboration, just because it's not anything we've ever done before. And so I really want us to dig hard and kind of look, deeply at how can we get more innovative in the people we partner with, right? Where are some of those non-traditional partnerships that we could really start to think differently about the work that we do?
Yeah, looking forward to that discussion because I know there's so much we could say in that space. So looking forward to next time. Today's the Recovering Politician Self-Care Policy of the Week, using rest time. Jason, I am a recovering workaholic and I don't know how to rest very well. I always seem to have to be doing something. Even I don't like going to a movie theater because I'm stuck in one spot for too long and I feel like I should be doing stuff. So if we're watching a show at home, watching a movie, I'm up doing something or have something else in my hands and I'm just not good at it. And so in the summer, it's even more hard for me because I'm just on the go, loving every minute of it, traveling for speaking, being able to take some time off in between, all the things. And it's so much fun. But then if I'm not paying attention, I have so much fun that I'm exhausted. And so I don't know about you, Jason, but for me, for summer, I just need to remember to put it on the calendar. You got to have some rest because that's when I think more clearly is when I'm taking some rest. But what about you, Jason? What is your self-care this week for summer?
I'm guilty of being just like you in those areas. I always have to be doing something. And so my wife holds me accountable because she's like, sometimes we just need to sit and that's okay. And I'm like, what? We can't do that.
No.
And so, there's some times that she's going to come along with me for some things this summer. And she's like, I'm going to the spa. You go do whatever you do, but I'm going to be gone for a while because that's how I relax. And you can go do whatever you want. But I'm going to go relax. And so, we've come to an understanding, but I am doing a better job of slowing down and just being sometimes because it's important just to slow down and be sometimes.
Absolutely. Well, today we talked about the workforce and some of the challenges that are out there, specifically behavioral health, but it's not just limited to us. It's about healthcare in general. Gave you some background in the show notes today. You can see some data on where we land in behavioral health and some of the challenges, but also what are some of the things we could be doing to improve our behavioral health workforce, and talked about that. Next time, we're going to get together and dive a deeper dive into telebehavioral health and innovative partnerships. Hope to see you then.